Okay, thank you for joining us for this presentation today. We're going to be talking about population health and giving a demonstration into that. The first thing we want to talk about, though, is just to give a little bit of example about how we can improve population health through clinical episode analysis. And I think a good way to start that is with an example story. And I'm going to use something from my own family. I had a family member last year who unfortunately was running and had an accident and tore a cruciate ligament in her knee. And we were able to get her into a primary care physician very early the next day, who looked and examined and clinically diagnosed a torn cruciate ligament, and then proceeded to do an ultrasound because a radiology image wouldn't have been appropriate at that time, and diagnosed, yes, indeed, there was a torn cruciate and it needed surgery to rectify that as soon as possible. So we booked the surgery for the very next day, and that was done on time and on the correct leg, which isn't always a given in healthcare today. And she was recovered perfectly well and sent home with good instructions. And data shows us that follow-up to surgery is really important in driving great health outcomes. And she was given physiotherapy, follow-up clinics, and within a couple of weeks of the operation, she was back to her usual self, running around and in a great shape. And that's a great story of a health outcome, and it's exactly what we want for all of our population when they have a need for care in that way. But the kind of crunch of this is, or the issue with this is the family member that was affected by this. And let me just show you who it was. It was my little dog, Abby, and she has recovered very well and is still running around and enjoying life. But the reason I like this story is because it's exactly what healthcare should look like. And it was really easy to deliver that kind of care for a dog because there was very limited episodes and very limited interaction with her as a patient. When we think about healthcare for us and for our families, we have a much more complex relationship with our providers, with our payers, and with the various processes that have to occur through our treatment processes. And what we're going to show you today is just helping to understand those episodes of care and how we drive the same outcomes for all of us. And there's nothing new about this. In this picture, this is Florence Nightingale, credited with being the founder of nursing back in the mid-1800s. And she was also a PhD statistician. And what she did was she was able to show that if you looked at the data of why soldiers were becoming more critically ill and dying after being exposed to healthcare, you could create visualizations that would just show exactly what the cause of death was, where it occurred, and why it occurred. And those visualizations were presented to the leadership of the military at the time, and she was able to show that with better nutrition, sanitation, and overall general hygiene, you could reduce your mortality rate significantly. So we appreciate the idea that the use of analytics to drive better patient outcomes in a population is really nothing new and something that we could do much more with in our current time. So why is it important to do health analytics like this and to really drive patient outcomes? Well, I think we really want to understand which of the populations that are most likely to become sick and how they're going to trend. We really want to understand where that social determinant data fits in as well, and we're seeing more cases now where social data has become a driver in making changes. We want to predict negative outcomes, and we want to start to employ strategies and change management so that we can drive a higher safety and a better outcome healthcare at a lower cost. And this is the process that we go through to get there. We integrate our data, we add our accelerators, we think about out-of-the-box capabilities that bring rapid deployment and great time to value, and then we have our end-to-end analytics. We want to visualize, deploy, and then start again with a very circular kind of iterative process that allows us to continuously improve our healthcare system. So with that, I'm going to pass across to Jeremy, who will take it forward from here.
Thank you, Greg. So I'll just do a quick introduction. So it's Jeremy Racine. I'm a global healthcare artificial intelligence principal working in the SAS Health Analytics practice. So Greg talked a little bit about population health, outcomes analysis, with a specific focus on clinical episodes of care. And I think it's a great segue into the demonstration portion. So we're going to start off really at 100,000 feet, a true population view, and using a variety of different data sources and analytics, we've pulled together this population health visualization. And we've also run this data through our clinical episodes of care. And so, as Gregory mentioned, getting a comprehensive view of care is an essential element of this process for population health. And as I had mentioned, so we're running all of our data through these clinical episodes of care. There are a variety of different clinical rules, definitions that are used to define these episodes of care. And by doing so, we get this nice comprehensive view of care that occurs before, during, and after. Think about the, perhaps not Greg's dog, but perhaps yourself or a family member who might have a orthopedic surgery, and there's all of the care that happens before, the surgical event itself, and everything that happens after. All of that is a clinical episode of care. Now, that care is also split in to a different couple of pieces. All right, there's the typical care, which is the care that you should receive. And then there are a set of complications, hopefully things that you do not receive. These are what we call potentially avoidable complications. We use those as measures of quality. In addition to that, we also do a variety of different risk adjustments, risk calculations, so that we can stratify our population by risk. And with that, we can take a look at this particular visualization right now, and we'll begin by looking at risk. So at the top, you can see that we've stratified our population across the state of New York here by various levels of risk. So we're looking at critical, average, low risk. Again, those are created based on out-of-the-box analytics that run behind the scenes in that episode analysis process. And as we click on these, we'll see that we get some interactions with the below. Now, in addition to just looking at critical risk, because that's one of the areas we want to focus in on, right? We want to look at where are the highest risk patients? Where can we potentially look at areas for intervention? These are the areas that we like to focus on the most, the critical risk population. We've got some other ways in which we can filter down a little bit more. So, of course, in the States, we have different insurance payers, and so we can filter down on different insurance payers. You'll see we have ones that are familiar to most folks: Medicare, Medicaid, and our commercial insured population, which is the majority of the population. Let's go ahead and click on commercial. Now, we have some options, of course, for age brackets as well as race. We're just going to keep focused on the commercial for a second. I want to draw attention down to the bottom. Now, you'd seen while we were clicking on the filters on the top that the map on the bottom changed. And we've got a couple of different things. So we're looking at, on the left-hand side, we're looking at a color gradient, which represents our risk of our population, where the stronger red colors are higher risk parts of the population. And on the right-hand side, we're looking at more of a cost perspective. On the right-hand side, we're looking at what we call an average to expected cost. The expected cost is that analytically driven cost versus what the average cost is. Where we see areas of red, it means that the costs are actually higher than what the analytics said they should have been. Now, when you look left and right, you can see if we scroll over some of these, there are a couple areas where risk correlates to cost. One of those areas we'll just focus on is Niagara County right here. And the reason we mention this is because just because a location has a high-risk population doesn't necessarily mean that the costs are unavoidable. Some places just have high-risk populations, and they happen to be providing the care that is necessary for that population, which means it is not necessarily what we call a potentially avoidable complication. But we'll focus on Niagara because Niagara has both a high-risk population and, on the right, as you can see, has a higher than normal average to expected cost ratio. Now, you can see there's a variety of different scores in here, things like outcome scores, preventive scores. These are all types of things that funnel all the way to the top for the risk stratification process that we've done. We click on this, and we can get some additional information very quickly. So you see, we peeled the onion back. We just drove right down into Niagara County, and now we're down to a zip code level. And you'll see we've got a variety of different filters here. We can learn some more about that population that might be driving those high costs, those poor outcomes in this particular county using analytics. We can look at hospitals, long-term care facilities, and outpatient facilities. I'm going to focus on hospitals because they tend to be the highest costs. And you'll see on the bottom, we've got some different colors here, okay? So we've got a couple of zip codes, and I'll explain that in a second. The color represents those complications that we talked about. So the stronger blue gradients represent higher amounts of complications. The bubbles represent complications as well, but the color of the bubble represents the cost. Okay, so we're looking at deeper blue colored zip codes, which is one of the ones we can see right here, this 14094, with also large red bubbles. Okay, this would indicate, the analytics are indicating that we have a tremendous amount of complications and significantly higher costs. Okay, so just focusing in, and we'll click on this one particular hospital right here. You'll see on the right-hand side, we've got some additional information. We've got a readmission rate, which is astronomically high for this particular hospital. And we have that expected to average cost for inpatient stays. There is a significant variation, as can be seen there, nearly $20,000 difference. There's something going on, of course, at this hospital we need to learn a little bit more about. But you also see, while we're looking at this, two other zip codes. And why do we put the other zip codes in here? Because you may have a disproportionate number of folks who are going to this facility, experiencing these complications and these high costs, but were they aware that maybe within 15, 20, 30-minute drive, there are two other facilities in these neighboring zip codes, which, as you can see, have low number of complications and significantly better costs. As you can see, almost spot on right here. So there are alternatives. Again, we're building a blueprint for potential change here. Let's focus back on Niagara Hospital here, Eastern Niagara Hospital, and learn a little bit more about what's going on there. We can click on this, and you'll see that we get some information about the episodes of care that are occurring. Now, episodes of care can be rolled up to what we call condition classes. So they're spread out into chronic, procedural, and acute conditions. The larger boxes here represent higher costs. The stronger color green represents higher complications. Chronic, which is both the largest, so the highest cost, total cost, and the strongest green gradient is also the highest in complications. Let's drill down into that and take a little bit deeper look at the conditions that are driving those costs. And when we go ahead and drill in, you'll see that one of these boxes pops out almost immediately, and that would be CHF, congestive heart failure. Tremendous amount of complications as compared to the other conditions, 50%, and tremendous amount of costs. Now, when we select CHF, I will say to focus over here on the right-hand side, and you'll see we have on the top a trend line representing the actual costs, the green line representing the risk-adjusted costs created by the analytics, and on the bottom, the complications costs. And what we can see is that they've trended up over time, and their projections, which are automatically created here from the analytics, show a projected upward trend. Let's learn a little bit more about the complications that are driving this. Again, as a part of the system, we identify those complications. They help in terms of creating a blueprint for change. You can see by taking a look at the top complications with this CHF cohort at this one hospital, that sepsis, pneumonia, acute kidney failure, these are some very serious complications, and they are the top complications here. And we can see how they shake out on the left at this hospital versus the right, which is the state average. So clearly, having used the system, we're starting to develop some very granular details about what might be driving these costs. We've got a particularly problematic cohort at this hospital, complications such as sepsis, pneumonia, kidney failure. Let's drive maybe one layer deeper, and we can do that here. We'll just go over to what we call provider cost. Let's take a look at the providers that are providing these services. And we're going to look here at an intersection of using not just claims or clinical data, but using hospital operations data to better understand what might be going on. And so I've got my providers here. These are some of my higher cost, higher complication providers. And you can see one of them just pops out. High cost, represented by the size of the box. Stronger complication, represented by the green. And you can see tremendous amount of complications. Something going on here. Let's draw our attention to the bottom. Potentially avoidable costs for this particular provider have been trending higher. But let's look at some operations data and see how the combination of these things can be incredibly compelling when we look at ways in which we can intervene. Patients per hour, these don't come out of claims, they don't come out of clinical data, they come out of a hospital operation system. And we can see that the patient volume started relatively standard, around 2 patients per hour for this particular physician, but over time has increased to 3. Now remember, in that same time frame, complications have gone up. Sepsis has become more of a problem. Let's take a look at this with even a more granular lens. On the bottom, these bars represent sepsis mortality rate. On the top, we have the average physician response time to a sepsis bundle. Collectively, we can see is over the same time frame that the operations data told us that there was an increase in patient volume. We can see that sepsis mortality has more than doubled on the bottom, and the response time to sepsis has gone up nearly an hour. We're getting some very concrete information now about what might be going on. So I'll pause there. For one of the questions we'd want to ask is, what could we do if we applied some advanced analytics to this problem? Could we potentially create a new intervention, especially in regards to maybe identifying potentially septic patients at an earlier stage in the care process? Now, to talk a little bit more about those analytics and how we could create them, I'm going to pass over to Hiwot.
Thank you, Jeremy. My name is Hiwot Tesfaye, and I'm a data scientist in SAS's Healthcare Industry Solutions Group. What I'll be showing you over the next few minutes is how we can use predictive modeling as part of a clinical intervention solution. What Jeremy showed us over the last couple of minutes was how we can use population health dashboards in order to identify potentially avoidable complications that are not only driving up costs, but most importantly, are leading to poor health outcomes. So once we were able to identify that our congestive heart failure patients had a leading complication of sepsis, we can start thinking about what kinds of advanced analytics techniques we can potentially use in collaboration with other process improvement measures to help mitigate these issues. So in order to identify first our patient cohort of interest that we can use as part of our model training process, we actually turn to SAS Cohort Builder, which is part of the SAS Health offering. Cohort Builder is designed to take in a variety of healthcare data spanning from demographics, data, labs, prescriptions, procedures, and diagnoses, and much more. And we can use a GUI interface to quickly identify patients that have a history of CHF, and then start identifying our target variable, which will be sepsis, in a time-dependent manner. Once we have our data set built in Cohort Builder, we can bring it into Model Studio, where we can train various machine learning algorithms, or we can put it into SAS Studio, where we can further augment the data before we pull it into a machine learning algorithm. So for this demonstration, I'm just going to go through Model Studio and demonstrate how an interface like this can dramatically increase the efficiencies of a data science team that might be working in a healthcare setting. So now that I know my data is ready, I can navigate over to the Pipelines tab. You'll notice that on the left-hand side, you have various options available to you in order to build out a pipeline like you see on the right-hand side. So we have data mining pre-processing options that allows us to manipulate our variables before we feed them into any kind of model. In the bottom, we have supervised machine learning algorithms available to us, anything from a simple decision tree all the way to neural networks. For post-processing, we have the ensemble option, so we can ensemble our models together. And then under miscellaneous, you have various options to further explore your data. It'll automatically build out charts of cardinality, missing variables, distributions, various other things for you. We have an open source code, which is pretty nifty, which allows us to pull in Python or R code within our pipeline flow. We also have SAS code and several other options. So using these objects on the left-hand side, we're able to build out a pipeline like this that always starts off with the data. The data is then fed through various data manipulation options, in this case, imputation, and then we're going to pull in some open source code before pulling it into a predictive model. So the nodes in purple are all supervised machine learning models. There's around 7 of them, almost all of which are all SAS models, except for this Python model. So I'm going to open this up and just illustrate to you that in the code editor, we're pulling in the scikit-learn package, and eventually we are running a random forest classifier model from scikit-learn. So this is just an illustration of how we can pull in open source models and compare them alongside SAS models. In the next and final tab, I want to illustrate one of my favorite features that has been included in this release of SAS, which is AutoML. So all I have to do is provide SAS my data set and tell it how long to run the AutoML generation, and it creates this entire pipeline for me. So all of this is editable, and I can change things as needed, try out additional models that it didn't consider, and basically just look under the hood and see what is being created here. So just note that for every node on the right-hand side, there's a properties panel that allows me to change hyperparameters of each of my models and other options that I may have available to me. I can also perform auto-tuning, which is an optimization technique that allows me to select the best hyperparameters for a particular model for the data set that I've provided. And then finally, in the pipeline comparison tab, what we're doing really is looking across all the different pipelines that we've created and trying to find the champion model for the validation data set across various fit statistics. So in this case, we're looking at misclassification rate, AUC, and KS statistic. So as we can see, the gradient boosting 2 from the AutoML pipeline had the lowest misclassification rate, one of the highest AUCs, and the highest KS statistic, and it's been selected as the champion model. When we're building something like a sepsis model that will be used in a clinical setting, and the end subjects that are going to be affected by this are real people, patients, it's really important to keep in mind that interpretability of these models and accuracy of these models is going to be of utmost importance. So here we can see the variable importance list. So we have diastolic blood pressure and the age of the patient, a bunch of other variables that are feeding this gradient boosting model that we've identified as a champion. However, we would want to know how these variables are impacting the score that's going to be given to each of those patients that the model is labeling as high risk for sepsis. And one way to do this is to look for the model interpretability charts that are available within SAS. So there's several that we have available to us. When we go into the model interpretability tab, we can see that we have variable importance lists, which we just saw, as well as partial dependence plots, ICE plots, line plots, and kernel SHAP values. That allows us to understand how the model is, how each variable is affecting the overall model, as well as how it might be affecting an individual observation or patient. To get a better understanding of what each of these plots are trying to explain, when you click on this button, there's some natural language generation going on here to explain what each of these plots mean and makes it relevant to the values and variables that are actually present in this plot specific to your project. So now that I've identified a model that I feel like has a pretty impressive accuracy on my validation data set, the next thing I might want to do is register this model into Model Manager, which allows me to track its accuracy over time and make sure that its accuracy is not degrading, and if it does, to label it for retraining. And the other option is to publish the model. So once I publish it, the API endpoints will be made available for third-party applications, web app, mobile apps to make calls to this model, or I can publish it and visualize it in a dashboard similar to what we were seeing in Jeremy's section of the presentation. So from here, I'm going to hand it over to Jeremy to talk a little bit about what we might do with the output of this model that labels our patients as at risk or not at risk for going into septic shock.
All right. Well, thank you, Hiwot. And as Hiwot was working through a lot of the advanced analytics that go on behind the scenes, a lot of things that we had talked about, we wanted to take an opportunity to look at what things would be like if we were to operationalize those analytics. We saw some of that stuff, of course, up front, but what Hiwot has done is specifically worked on a model that would help to predict the likelihood of somebody potentially being septic in our hospital. And so if we wanted to take that model, operationalize it, put it in there today or tomorrow, we wanted to take a quick look at what that would be like. And so we've got a visualization here, and as you can see, we've got a risk stratification filter at the top again. And so again, taking the results of that model that we've operationalized, now we can stratify our population into being a high risk, medium risk, or low risk. So let's take a look across our entire patient census and see how many folks, based on the new model that Hiwot created, are in this high risk group. We can see that there are 29 patients. There's a variety of different demographic variables and other impactful variables that you recall seeing in the modeling process. Those are all below. But let's take a look at those actual patients too. And what we'll see is the model went a little bit further than that as well. So we take the model and not only look at those that are high risk, but also in this case here, kind of almost another level of criticality. Who are the most highest priority based on a variety of different factors. And again, these are all types of things that we configure inside of the modeling environment. But you can see highlighted in red are our most critical patients. We have access to all this information. Again, all this coming in from clinical data sources, but also things that could be coming in from devices. We have a lot of interoperability with medical systems in general. So we'll hop out of there. And what we'll do is take a look at the last piece, which is we've been talking a lot about interventions. And if we wanted to come in here and take a look at how we could play a bit of a what if game with interventions, we provide our users with that capability. And so as you can see here, we've got a variety of different interventions on the left, different types of outcomes and how they're impacted on the right, including cost at the top. You can see we've already have selected a few of them, but they're very simple. We just come in here and we select which intervention we'd like to employ. And based on a variety of analytic models running behind the scenes again, we will calculate the potential cost savings as well as the impact to those various outcomes, such as sepsis mortality rate, average length of stay in the ICU, readmission rate, sepsis rate, and that physician response time to getting a sepsis bundle order in. So you get a quick kind of overview of how we can take those advanced analytics that Hiwot was working on and how we operationalize them very quickly so that folks can understand what interventions they might want to take and how they can improve outcomes and potentially better manage costs. With that, we'll pass it back to Hiwot for a quick wrap up. We thank you for your time.
Thank you, Jeremy. So to recap, Jeremy showed us at the beginning of the presentation how we could use SAS Health to organize our healthcare data into clinically relevant episodes of care. looking at our data in this manner through dashboards, we can uncover opportunities for improving health outcomes and reducing costs, with a specific focus on potentially avoidable complications. We're able to understand the demographic and social factors that drive outcomes as well. Because we have AI and machine learning capabilities as part of this offering, we're also able to train machine learning models on our patient data sets and consider a data-driven solution as part of our intervention process. We're also able to monitor these models over time and ensure that the most accurate and interpretable model is being included as part of the solution. Thank you all for your time today.